The following patient I will describe is a 78-year-old male who had complaints of chest pain in the right thoracic region, in which his physician had requested a rib X-ray examination. Protocols at this site are seen above with a female patient reenactment. This is the doctor's report for the right rib radiographs. The clinical information was pain. Comparison, none available. Findings: there is no evidence for a rib fracture. There is no infiltrates, which in this case refers to pulmonary infiltrates regarding to substances denser than air, which accumulate in excess of normal within the parenchyma of the lungs. Pneumothorax, which is collapsed lung, or pleural effusion, which is a fluid between the tissues that line the lungs and the chest, and the right lung field. The soft tissues are unremarkable. The remaining bones are unremarkable. There is extensive spondylosis of the thoracic spine, which is deterioration or degeneration of the soft tissues in the spine. This is not as common in this region as it is to the cervical and lumbar spine regions. The aortic valve is calcified. There is prominence of the right hilum. Impressions: intact rib series. Recommend full chest PA for evaluation of the right hilum. Take a deep breath in, hold your breath, breathe. Step to the left. Take a deep breath in, hold your breath, breathe. Now I will talk about the same patient who came in 10 days later for a chest X-ray examination, as recommended by his physician. At this time, he came in with complaints of pain in the right thoracic region when breathing. The reason for mentioning the previous rib examination is because it has correlation to his latest chest X-ray examination report findings. The indication for these findings were positive PPD, history of chest pain, and smoking history. Technique: 2 views of the chest are performed. Findings: the right hilum is markedly enlarged, with the hilum overlay sign suggesting possibly a lung lesion and not a hilar lesion. This correlates well with the recent rib series. Rest of the lungs are clear, with diffusely increased pulmonary markings. The cardiac silhouette is upper limits of normal in size, and the aorta is somewhat tortuous and calcified. Impression: diffuse interstitial disease with suspicion for right lung mass. Suggests CT follow-up. The lung mass is approximately 4 by 5 centimeters and could be related to the hilum is more likely a lung mass based on appearance. I could not exclude active tuberculosis based on this finding. Firstly, I will note the lung mass approximation of 4 by 5 centimeters. This term is specific terminology regarding to the abnormality of more than 3 centimeters, in which a nodule is less than 3 centimeters. This also corresponds to tumor TNM staging system level T2A. The primary diagnosis being diffuse interstitial disease, referring to a broad category of diseases as a collective, based on their clinical appearances, but of diverse causes and treatments. The interstitium is the area between the capillaries and the alveolar space, and the relative approximation for efficient gas exchange. The diseases within the collective can be broken down into either known or unknown causes, and are further broken down into organizational classifications. Common symptoms are a non-productive cough and exertional dyspnea or breathlessness. The most common interstitial lung disease, ILD, in the United States, and is recognition on a plain radiograph, is sarcoidosis. This is an idiopathic inflammatory disorder that affects the lungs, which is more common in younger adults than older, but has a common manifestation of asymptomatic hilar adenopathy, which is an enlargement of the hilum. The second most common type of ILD is idiopathic pulmonary fibrosis, IPF, which has a strong association to cigarette smoking, with majority of the patients older than 60 years old, and a more rare occurrence in persons of 40 years and younger. The prognosis of persons diagnosed with general diffuse interstitial disease leads to impaired lung physiology due to inefficient gas exchange, thus decreased lung volume and a higher morbidity rate. Hypoxemia, which is a low level of oxygen in the blood, is a common trait and usually treated with oxygen therapy and may be prescribed. Pulmonary rehabilitation, along with exercise therapy to build aerobic fitness and to improve quality of life, is also prescribed.